then because it's not in PowerPoint. Okay, everybody see this presentation in chat in WhatsApp? Then can you please tell us based on the photo that you've sent in WhatsApp, okay? It will be quicker. Okay, we are listening to you.
Should I talk?
Yeah, you're welcome.
Okay. Yes. So we have the difference between the sympathetic and the parasympathetic nervous system. As we know, the autonomic nervous system is divided into sympathetic and parasympathetic and enteric nervous system. So I go first with the sympathetic nervous system, which is arise from thoracolumbar outflow from thoracic number 1 until 12 and lumbar 1 and lumbar 2. So generally it is like active in the condition stress and emergencies, fight, flight, fight. And also like stimulation leads to like dilatation. So when it is happening, like it's dilatation of the pupil and acceleration of the heart rate and decrease peristalsis of the esophagus. Also with the lungs, like it dilates bronchiales and digestive system, like it is constructs of the gastrointestinal organs. Also the sweat glands, like it activates sweat secretion, and digestive tracts like inhibits the
Peristalsis, yeah.
peristalsis. Yes. In the kidney, like it increase like renin secretion. In the veins, like inhibit like tumescence.
Okay. And when sympathetic nervous system activates, remember yourself before the exam. This is how it looks like, how you feel, and like, or in some huge stress. Okay, and then parasympathetic nervous system, that one of the main parts of it is 10th cranial nerve, vagus nerve. Okay, and effects.
So yes, it is arise from the craniosacral, like it is go from cranial nerve 3, 7, 9. Someone will need to enter, just I will add him.
Yeah.
So it is arise from cranial nerve number 3 and 7 and 9 and 10, and sacral 2, 3, 4. Generally, like it rebuilds the body like resources during the rest. So also, so when it's happening, like it is construction of the pupil, stimulation of the gland secretion except sweat glands. It's also like slowing the heart rate and increase the peristalsis of the esophagus. In the lungs, like it make bronchoconstriction and increase secretion. Also, it is increase motility and secretion and increase constriction and increase secretion. It's also increase stimulation of the intestinal peristalsis and inhibition of sphincters.
Yep, and who remember, if we talk about 7th cranial nerve, you've already had the class. Parasympathetic fibers are responsible for what? In 7th cranial nerve, who remembers it's from the previous class with Luisa Talgatovna? Who remembers?
It's responsible for taste and salivary glands, and also the tears in the eye, as well as expressions. And it's a facial nerve, right?
Yeah, facial nerve. Yeah. Yep. Good. Third cranial nerve we will discuss on the last class on the 1st of October. Okay, and then 9 and 10 already discussed. Okay, then guys, switch. Thank you very much, Mahmoud, for the good slide that you share with us. And then we should start tasks about 9, 10, 11, 12 cranial nerves. And I would like you to read it as you do for Louisa Talgatna for your homework. Task number 1 is the first one. Task number 2 is another one. I have Russian version of tasks. That's why I would like you to read it to everybody. Okay? Can you do this? Task number 1. Who is responsible for this task?
Me.
Okay. You're welcome.
Which task?
Task number 1. Topic about bulbar pseudobulbar syndrome, 9-10 caudal group of topic number 6 in our Russian tasks. Do you have them?
Oh,
Or you don't?
I have. Wait.
Okay, relax. Just do this. Because I would like you to understand the logic, how we examine the patients and then how we analyze.
Professor?
Yeah.
That's one of the tasks yesterday was on Tuesday when I was telling you that some of the tasks are not present in the task that the professor.
You don't have them, yeah?
No.
You also, okay. What I can do, I can translate it from Russian into English to you. And then you should write down like the symptoms and then analyze it and we will analyze them together, okay? Is it okay?
Okay.
All right. Task number 1, man, 70 years old, he has problems with articulation, like porridge in the mouth, and has weakness in his left extremities. While examination, we can see that deviation of the tongue to the left, no visual changes of the tongue, and in left extremities, decrease muscle strength, brisk reflexes, and Babinski sign. That's all what we can see. Porridge in the mouth, deviation of the tongue to the left, no visual changes of the tongue, and in left extremities, muscle weakness, increased or brisk tendon reflexes, and Babinski sign.
Central paresis.
Again, central paresis where?
In the right.
No. Why right?
In the left. Gyrasis.
Yeah. Okay, left side muscle weakness, increased tendon reflexes, and Babinski sign. Again, 2 syndromes here. Paresis, yes. Where and is it central or peripheral?
Left-sided central paresis.
Yeah, left extremities means that it's hemiparesis. Both extremities, upper and lower, left side, central hemiparesis. Yes, and if we talk about tongue, how do you think? And try to remember from the previous class, is it central paresis of muscles of the tongue or peripheral?
Central.
Yes, it's central, and please prove it to me. It's absolutely, you're absolutely correct, it's central.
Upper motor lesion.
Upper motor lesion, yes, but why clinically it's central? How we can be sure that it's really central, not peripheral?
Deviation tongue to the left, and
Deviation, yes, but
and
can we see any visual changes
no,
there? No.
this one.
If it's peripheral, then usually we will see muscle waste of muscles, muscle waste, and can see fasciculations. Here, no, only deviation. Yes, and this is central paresis of muscles of the tongue. Okay, and topical diagnosis, which part of the nervous system is damaged in this case?
Coronary, coronary,
Can
and
be.
internal.
Which side? Which side? Right or left?
Right upper
Right.
motor region.
Yes, yes, perfect. Right side, contralateral, brilliant. One of the common tasks in real life that we see in patients with strokes. No methods of investigation here, no MRI, of course. What else we can do here? Is it easy? Guys,
Somewhat.
easy. Okay, then next task. Woman, 65 years old, also has problems with speech, like porridge in the mouth, and weakness in her right extremities. Upon investigation, in 1 month after the onset of symptoms, she has deviation of the tongue to the left while protruding the tongue, atrophy of left part of the tongue, muscle weakness in right extremities up to 3 points, and increased tendon reflexes, and Babinski sign on the right. Which syndromes this patient have?
Professor, can you repeat it again?
Okay, porridge in the mouth and weakness in right extremities. In 1 month, upon investigation, we can see deviation of the tongue to the left, atrophy of half of the tongue, left half of the tongue, and muscle weakness in right extremities, increased tendon reflexes, and Babinski sign on the right. So, I'll draw the picture for you. One moment. Hey guys, who can tell me the syndrome? So I'll draw the person. I'm not very good at drawing, but I'll try. Citation. Okay, I'll draw the person for you. Okay, guys, I'm not very good at drawing. I absolutely know it, and it's really like this. Okay. Can't see myself. Okay, this is the person. Can you see it?
Yes.
Yeah, this is left side. This is right side, and right side is paretic, increased tendon reflexes Babinski sign, and tongue deviates to the left, and left part of the tongue is atrophic. Which two syndromes does this patient have?
Is it central hemiparesis on the right side?
Yeah, right side central hemiparesis, absolutely perfect. Then about the tongue, atrophy of the half of tongue.
Is it peripheral paresis?
Yeah, this is peripheral paresis of muscles of the tongue. Absolutely.
Do we also say like do we also go further and say that which part of the tongue is paresis? Like,
yeah, you can say left part.
okay.
Left part, yeah. And what is it when clinically one side on the face is peripheral and contralateral hemiparesis? It has special name. Who know? Any ideas? Because when peripheral lesion is on one side and then contralateral central hemiparesis. Who any
Brown sequoia syndrome?
again?
Brown sequoia.
No. Guys, Brown-Séquard syndrome is the lesion of one half of the spinal cord. No, this is alternating syndrome. Jackson's alternating syndrome. When the patient has dysarthria, like porridge in the mouth, it's dysarthria, deviation of the tongue to the side of the lesion, see, left side is paretic, and contralateral hemiplegia. And this is the lesion in pyramid of medulla oblongata. Left side pyramid of medulla oblongata, usually due to strokes. Very, very, very common stuff in patients with stroke. And again, here the lesion of 12 nucleus of 12 cranial nerve in medulla oblongata, and contralateral we see hemiparesis. This is Jackson alternating syndrome. Alternating syndromes, all alternating syndromes that we can see in patients with lesions in 3, 4, 7, 6, 9, 10 cranial nerves will be like the question for students who would like to improve their mark at the exam. Have you got it? Alternating syndromes, then the lesion is in one part of the brain's term, usually with involvement of nuclei of specific cranial nerves and contralateral symptoms on the body. Is it clear?
Yes.
Perfect. Okay, then next task. The patient of 40 years 2 months ago has returned from Siberia, and she had ticks bite there. Has atrophies of both trapezius and sternocleidomastoid muscles, decreased muscle strength in these muscles. He can't shrug and turn his head to the right, two sides. No other neurological changes, no sensory disturbances, no other focal neurological signs. Neurological syndrome and localization of the lesion, what it can be. Who knows? Guys, ticks bite, Siberia, atrophies of and muscle weakness of trapezius and sternocleidomastoid muscles, both sides. Which cranial nerve is responsible for this?
11.
For this?
Accessory nerve.
Yeah, accessory nerve. And which one? Left one, right one, or both?
Both.
Both, yeah. And the reason here for this one is tics encephalitis. Tics encephalitis. And here usually have specific treatment of this viral infection. Good. And again, who remembers how we examine trapezius and sternocleidomastoid muscles? What we will ask the patient to do? To examine muscle strength of trapezius and sternocleidomastoid muscles. Who remembers?
We would put the hands on their shoulders and
Yeah.
close to their neck and push down while asking the patient to shrug the hands off. And then we would turn the head to the side while forcing it on that side and asking them to push it on the other side.
Okay, if we
the
would like
opposite
to
side.
examine right sternocleidomastoid muscles, to which side we ask the patient to turn the head? Right muscle.
To the left.
To the left. Perfect, brilliant, you've got it. Great. Okay, task number 4. 10 tasks, then break, and then cognitive functions. Okay, task number 4. Woman, 60 years, she has choking while eating, lifting down of the right part of the soft palate, and decrease no movements while phonation, decrease of right gag reflex, and problems with an ageusia in posterior 1/3 of the tongue on the right. Classical neurological syndrome. Which cranial nerve is damaged here? Gag reflex, soft palate, no movement and lifting down of the right half, decrease gag reflex, and decrease of taste in posterior 1/3 of the tongue.
The glossopharyngeal nerve.
Yeah, which one, right or left?
Right.
Right side, yeah, right glossopharyngeal nerve, very classical itself. And of course here methods of investigation will be MRI to find out maybe it's some tumor there or something else what can compress it, and also MRI, MR angiography to find out maybe some vessel can also compress the nerve root and cause this clinical symptom. Brilliant. Task number 5. In real life, we can see quite huge amount of patients like with this clinical picture. Male, 70 years old, has hoarseness, problems with swallowing, problems with articulation, like porridge in the mouth, decreasing of movement of soft palate, both sides, absence of gag reflex, decreasing of limitation of movement of the tongue, atrophies and fasciculations in the neurological syndromes that this patient has. Okay, hoarseness is part of what? Hoarseness is part of yes, it's dysphonia. Problems with articulation, how we name it, how will you name the syndrome? Porridge in the mouth, articulation. This is who prepared the difference between bulbar and pseudobulbar syndrome. Who is that person? Remind me, please.
I must do it, but I didn't find any materials, so I didn't.
Okay. All right, but in this task again we can see hoarseness. It's the part of dysphonia, problems with swallowing, dysphagia, and problems with articulation, dysarthria, 3D syndrome, dysphonia, dysarthria, and dysphagia, and decreased movement of soft palate and the absence of gag reflex. Fasciculations in the tongue means that this problem is central or peripheral. Decrease in reflexes, idea is the same. Muscle atrophy, fasciculations, it's peripheral. Yeah, guys, and this is bulbar syndrome. Bulbar syndrome, dysarthria, dysphonia, and dysphagia. Atrophy, muscle weakness of soft palate, sometimes also can be paresis of vocal cords sometimes. And if it's bulbar syndrome like here, then decrease of soft palate and gag reflexes. And here localization of the lesion is of course medulla oblongata, and especially this ambiguous nucleus of the nerves, or like this beginning of these nerves in medulla oblongata. Reasons can be, in this case, it can be amyotrophic lateral sclerosis, sometimes can be strokes in this area. That's why here MRI and needle EMG, electromyography, to find out the special problems, potentials of denervation in muscles in patients with amyotrophic lateral sclerosis. And this is again bulbar syndrome, like peripheral paresis, muscle weakness, dysarthria, dysphonia, dysphagia, and loss of reflexes. Got it? Is it clear?
Yes.
Good. Okay, task number 6, half already done. Woman, 65 years old, has deviation of the tongue to the right, atrophy of the right half without fasciculations. No other focal neurological signs. That's all that this patient has. What syndrome?
Can you repeat it, please?
Okay, the patient has deviation of the tongue to the right, atrophy of the right half of the tongue without fasciculations. That's and no other focal neurological signs. Okay, this is paresis of muscles of the tongue. Is it central or peripheral?
Central.
Have a look. Atrophies, guys, atrophies. If we can see atrophy, what kind paresis? Paresis is it? Atrophies of right half.
Peripheral.
That's
Yes,
peripheral. Yeah, it's peripheral paresis of muscles of the tongue. Lesion of which cranial nerve again? Which cranial nerve can be damaged?
Setion.
Guys, tongue. Tongue. Which,
Tongue. Okay.
yeah. Which cranial nerve is responsible for muscles of the tongue?
Vagus nerve.
No. Vagus nerve is for laryngeal, pharyngeal muscles and vocal cords. Guys, pure motor nerve that is responsible for muscles of the tongue. The last cranial nerve that we have, the 12th one.
The hypoglossus.
Hypoglossus, of course,
Yes,
hypoglossus nerve. And here, guys, hypoglossus nerve lesion in somewhere. It can be in nerve itself while it goes, or it can be again in the. But guys, for nucleus of each cranial nerve, especially for this motor nuclei, we can see fasciculations if nucleus are involved in the process. Here, no fasciculations. Looks like it's not the nuclei of this hypoglossus nerve, but the nerve itself. Here again, we need to find out what is there on MRI, because here can be polymyelitis, can be again amyotrophic lateral sclerosis, syringomyelia, and like sometimes we can see it in patients after strokes. That's why here, of course, we need additional information about anamnesis and how quick it appears, what was before, and which risk factors this patient has. But here again, syndrome, peripheral paresis of muscles of the tongue, lesion of 12th cranial nerve. Got it? And the last 4. Task number 7, easiest one, your examination task. Woman of 50 years old, after the operation on thyroid gland, has hoarseness. While or during laryngoscopy, we can see paresis of right vocal cord. That's all. No other focal neurological signs. Which branch of which cranial nerve is damaged here?
The vagus nerve.
Yeah, vagus nerve, yes. And which branch, specific branch of the vagus nerve that it can be damaged during the operation on thyroid gland very often?
The inferior.
No, not inferior.
No.
Recurrent laryngeal nerve. Recurrent laryngeal nerve, but branch of vagus nerve. Yeah, very often we can see it clinically after these operations on thyroid gland, because the nerve is very small, and for surgeons it's very easy to cut it. Methods of investigation here, they have already done laryngoscopy, but here we have anamnesis that this is because of thyroid gland operation, because sometimes also the tumor of the lungs can be the reason, but here we don't have any additional information about it. Okay. And if I'm not mistaken, we have also a person who should tell us about Wallenberg alternating syndrome. Am I correct? Guys.
I don't think so, Professor.
Okay. Then let's try to do this task. This is one of your examination tasks that will be at the exam in a little bit different symptoms, but idea is the same. Male 60 years old has problems with swallowing, hoarseness, lifting down of the left part of the soft palate, and decreasing of her movement while phonation, decrease of left gag and soft palate reflexes, decrease of pain and temperature sensation on the face on the left side, and contralateral on the trunk. Loss of pain and temperature sensation. First of all, what syndromes we can see here? Okay, problems with swallowing. How should we name it again?
Dysphagia or dysphagia.
Dysphagia, yes. Hoarseness. Hoarseness. This is dysphonia. Dysphonia. Dysphagia. Perfect. Okay, decreasing of the soft palate, decreasing reflexes. Again, is it bulbar or pseudobulbar syndrome here? Reflexes. Bulbar, yeah, bulbar syndrome, perfect. And loss of pain and temperature sensation on the face and contralateral on the trunk. Guys, if in task you see that some symptoms on the face on one side and on trunk any symptoms, paresis, ataxia, sensory disturbance, contralateral, it's always alternating syndrome. Lesion is in somewhere in brainstem, you need to analyze which cranial nerves are damaged. And after it, try to figure out what kind of alternating syndrome will be. And someone asked me, which alternating syndromes do you need to know? I'll just write them down here in chat for you. Which alternating syndromes you should know for exam, because again this is the question for like additional questions. If we talk about 5, 8 cranial nerves, you need to know Faville and Maillard-Gubler alternating syndrome. Have you heard about this stuff?
No.
Okay. Favil and Miyar Gubler. I'll type it to you. Sure about the spelling. Miyar Gubler. This is for 5-8 cranial nerves. If we talk about 9-10, this is Wallenberg, and this will be one of the alternating syndrome, one of the most common questions, additional questions. Alternating syndrome. And if we talk about 12 cranial nerve, this is Desjardins and Jackson. And another two we will discuss in topic about 9 and 4 cranial nerves. 9, 4, 6 and Jackson. And here in this task, the patient has half Wallenberg alternating syndrome. The patient has dysphagia, dysphonia, bulbar syndrome, loss of pain sensation on the face because of the lesion of sensory nucleus of which cranial nerve? Which cranial nerve is responsible for sensation on the face? Who remembers? Guys, sensation on the face provides with which cranial nerve?
Facial nerve.
Trigeminal.
Trigeminal, yeah, trigeminal, perfect. Here the lesion is in also involvement of the nucleus of trigeminal nerve, and contralateral loss of pain and temperature sensation. It's lateral spinothalamicus tract. You will discuss about this tract on Tuesday with Luisa Talgatna, sensation. And this is Wallenberg Zakharchenko, it's the Russian neurologist who also described this syndrome, alternating syndrome. The lesion is in dorsolateral part of medulla oblongata. You should know this syndrome absolutely for sure for the exam. And this is one of the most common syndromes that we can see in patients with ischemic stroke in vertebral or posterior inferior cerebellar artery. This is the stroke in vertebro-basilar system that we quite often can see. That's why please read about this syndrome again. This is Wallenberg alternating syndrome. Okay. And guys, the last one, and then we have 5 minutes break. The last two easiest tasks. Are you ready? Is it okay, or do you need a break now? Is everything okay?
Actually, can you repeat what's the name of the alternated syndrome?
Can you open the chat here?
Okay.
Yeah,
yes.
Can you see it?
Okay. Yes, I can see it.
Perfect. This is Wallenberg alternating syndrome. I'm not sure about the correct spelling, but like it's V or W, but idea is the same. You will easy Google it.
Okay.
Yeah,
Thank you.
Wallenberg syndrome, alternating syndrome is one of the most common stuff at the exam as additional question that you should know. Yeah, that you should know. And the last two tasks, and then short break. Task number 9. Male, 75 years old, after 2 cerebral strokes, he has choking while eating, hoarseness, porridge in the mouth, problems with articulation. limitation of movement of soft palate, both sides, but increased gag and jaw-jack reflex, involuntary crying, involuntary laughing, loss of muscle strength in all extremities, I think up to 4.5 points, increased tendon reflexes, both sides, and bilateral Babinski sign. Okay, again, choking while eating, how we can name it? Choking while eating.
Dysphagia.
Dysphagia. Hoarseness, it's again?
Dysphonia.
Dysphonia. Problems with articulation? Guys, problems with articulation. Dysarthria. Muscle weakness of soft palate, but increased gag and jaw-jack reflex, involuntary crying, involuntary laughing. Is it central or peripheral?
Central.
Central. This is central, yes. And guys, this is classical pseudobulbar syndrome. Dysarthria, dysphonia, and dysphagia, increased soft palate, gag, and jaw-jack reflex, and involuntary laughing, involuntary crying. Very often the patient can really sit in front of you and start laughing or crying without any reason for it. And we also can see some specific reflexes of oral automatism. So I will show you how to examine them. We have lip reflex, sucking reflex, and palmar mental reflex. It's pathological signs that we can see in patients with very long vascular anamnesis, the patients with arterial hypertension, angina pectoris, strokes in anamnesis that have these problems for many, many years. How to examine lip reflex? You ask the patient to put the finger to the lips and then hit the finger. Normally, absolutely no movement. But patients with positive lip reflex will move their lips forward, like duck, like this. And then again and again, they do it involuntary. If we see it, this is positive lip reflex. Sucking reflex, sometimes we can also use spoon and touch them between the lips, and also patient will move lips forward. Also, idea is the same. And palmar mental reflex, we ask the patient to give his hand to us and perform this movement and look and ask the patient to look up. Patient looks up. We do this movement and look to this part, to the mental part of the face. And if the reflex is positive, here will be the contraction of the muscle. Again, it's abnormal reflex. It's if we see like both reflexes, lip reflex, sucking reflex, and this one, or only one of them, it means that the patient has positive reflexes of oral automatism, and this is one of the symptoms of pseudobulbar syndrome. And pseudobulbar syndrome can be if patient has bilateral lesion of corticonuclear tracts, which goes to 9, 10, and 12 cranial nerves, usually in patients with huge vascular anamnesis. Got it? This is classical pseudobulbar syndrome.
Professor, I have a question.
Of course.
Do you have a lecture about pseudobulbar and bulbar syndrome? No.
I think no. Yeah.
We need to study them from the the book, the books.
Yeah, yeah.
Yeah.
And Professor, would you please write down the subject about bulbar?
Do you mean write down? Yeah, you can.
Yeah.
You should have it in the books, as I'll try to find it. The good one. Just 1 second. I'll try to show you that I have the correct. The good stuff about it is in Fundamentals of Neurology. There is the great stuff. If you can open the book, I can give you the picture for it. Just 1 second. I'll give you the picture. That's where you can find out this bulbar and pseudobulbar syndrome. Just 1 moment. Because there is very classical one. Guys, 1 second. Here's listed. 1 moment. I have so many stuff here that I need to find out where is the correct one. 12. Larynx. Okay, I will do. We have it in. Can you read in Russian, or it's absolutely impossible for you?
A little bit, I think.
A little bit, okay. A little bit means absolutely a little, or a little bit really.
A little bit. It depends on what. I don't know.
Okay, then 1 second. I'll send the picture to you. 1 moment. 1 moment. Okay, it's a little bit with my notes, but I hope it will be okay. So 1 moment. I'll put the stuff to you. Yeah, just 1 moment. I'll send it in WhatsApp to you. Change it a little bit. Yep, good. As I'll send it in WhatsApp. Yep. Okay. Can you see it?
Yes.
Yeah, this is bulbar and pseudobulbar. It is from your clinical book. I'll try to find out as well. During the break, I'll try to find out another table for you in
Okay.
English. That will be easier for you to understand. I'll try to do my best. But here is the brief one, and it's quite good. Written quite good. It's the Mayo Clinic book. I can send it to you if you have time for it. Quite difficult one, but good pictures there, absolutely. Just 1 moment, maybe I'll find. No, here nothing about this. Okay. During the break, I'll try to do my best and to find out another best stuff with table for it. Okay. Okay, and guys, the last task. And here in this task, another stuff. Muscle strength in all extremities, bilateral Babinski sign, and increased tendon reflexes, both sides. What it is? Any ideas? How will you name the syndrome? Increased all tendon reflexes, muscle weakness in all extremities, and
Central paresis.
Yeah, central paresis, but which side? If all 4 extremities are involved in the process, how will we name it?
Tetraparesis.
Mm-hmm. Yeah, central tetraparesis. Again, bilateral lesion of corticonuclear and corticospinal tracts. In patients with multiple strokes in anamnesis, it's quite common stuff. Okay, guys, just 1 second. I'll try to find another book. Maybe it's here. I can see you this type of dysphagia. I'll try to see the good table for you. No, okay, I'll try. No, not here. Okay, guys, and the last task in this topic, in real life, we also can see it very often. Here is woman. Again, she has choking while eating. Again, syndrome. Choking while eating.
Dysphagia.
Dysphagia. Hoarseness.
Dysphonia.
Problems with articulation.
Dysarthria.
Dysarthria. Limitation of movement of soft palate. Decrease of gag reflexes, but increase Georgiac reflex, involuntary crying. What is it?
Pseudobulbar.
Reflexes decreased. Gag reflexes are decreased, other reflexes are increased. Guys, in real life, patients can have mixed pseudobulbar and bulbar syndrome. Yes, in real life, it can be in patient with one disease. And here, symptoms for pseudobulbar syndrome: involuntary crying, increased Georgiac reflex, but for bulbar syndrome, decrease or absence of gag reflexes. And again, and then for extremities, the patient has muscle weakness in all 4 extremities, atrophies, articulations there, but increased tendon reflexes and bilateral Babinski sign. What kind of paresis this patient has?
Tetraparesis.
Tetra, yes. Is it central or peripheral?
Central. No.
Atrophies, fasciculations, but increased tendon reflexes and Babinski sign.
Central.
And muscles and atrophies and fasciculations.
Is it mixed?
Yes, it's mixed. Yeah, guys, it's mixed, central and peripheral. And here the lesion is both in corticonuclear and corticospinal tracts and nerves itself. This is very, very classical, guys, for one disease. If you remember, some years ago, there was ice bucket challenge. This challenge was for raising money for which disease?
ALS.
ALS, yeah, this is ALS, very classical. The patient can have mixed central and peripheral paresis. Usually these patients don't have any sensory disturbances. Cognitive decline can be disturbances of pelvic muscles, but these patients never have sensory disturbance. Guys, have a look. That's why here in this case, how we should method of investigation is needle electroneuromyography to find out the specific increased potentials of motor units that will be increased, and this is the very classical for this syndrome. Not very nice disease, but in real life we can really quite often see it.
Excuse me, Professor, can you repeat the investigation? Needle
EMG, electroneuromyography. Electroneuromyography. And okay. Well, okay, guys, then short break for 5 minutes, then cranial, then cognitive functions, and I'll try to find a good table for you with bulbar and pseudobulbar syndrome. Okay, just one moment, just send it to you. Okay. Just send it here. One moment. Okay. Then guys, relax a little bit and then we will continue. Guys, can you, if anyone stays here, can you see the picture in chat? Can you open it?
I can't.
You can, yeah?
No, I can't.
Can't. Why it's
I
down?
can see.
Okay, then.
Professor?
Yeah. Can you see?
Yes, for me, I can see.
This is 3 pictures, good pictures about difference between bulbar and pseudobulbar syndrome. And I'll send to Mahmoud the stuff and ask him to share.
Professor,
Yeah.
you want me to share them?
Yeah, if you can, I'll just send to Mahmoud again and stuff and the book from Mayo Clinic. But all these pictures, for example, who can't. Yeah, please. Oh, thank you very much, guys. I love your technical abilities. It's absolutely great. You are perfect. Instead of me, it's perfect. Yeah, great. Then cognitive functions. Thank you. Okay, then at 25 minutes, we will continue stuff. Okay, guys, are you here? Have you refreshed your brain?
Yes.
Perfect. Yeah, and guys, in WhatsApp, free pictures about difference between bulbar and pseudobulbar syndrome, quite easy, quite good. And the last one is about lateral medullary syndrome, is Wallenberg alternating syndrome. So we can see. Thank you very much, Nina, that you shared it with others. Thank you so much. Okay, guys, one moment, I'll bring one book and then bring pictures of my real patients with vascular disturbance, with Alzheimer, to show you how it looks like in real life. And who will be the rabbit for examining of cognitive functions? Who is the bravest one in the group? Who is not afraid of to show how you think, how you can analyze the stuff, and how the things goes? It's not very difficult.
I don't mind it.
You can. Perfect.
Yes, I think.
Brilliant. It's good. 5 in advance. Okay, one book. One moment. One moment. Okay, guys. Are you ready? Okay, we will, like, it's quite difficult topic. I know that it's really one of the difficult stuff in neuro, but we will start from the beginning. Have you heard the lecture in your portal about the stuff? About cognitive functions? As Luisa Talgatna asked you to do this.
Not yet, because for me personally, when I saw it, it was already too late and we had another class already. So.
Okay, I know, yeah, that for you it's quite difficult to listen to all the stuff. I got it. All right, guys, just 1 second. I'll open the book. I will give you like the brief material about it, and on next Friday during the last class we will be talk about first, second, 6, 4 and 6 cranial nerves. Topic is not very big, and if you would like, we can again discuss the stuff here if you have any problems and difficulties with it. Okay, because of course I can talk about it a lot, not even 1 hour. It's really quite interesting topic to discuss. Okay, cognitive functions that we examine, you should know some of them. You should know which cognitive functions maybe you know from like your general medical knowledge. Which ones do you know?
Like thinking and
Yeah, memory, thinking,
memory,
yes, yes, memory, thinking,
feeling.
feelings.
There's recognition of stuff.
Okay, there are some of them. Okay, the easiest one, memory. Memory that help us to remember and recall information. Remember, storage, and recalling the information, memory. Then speech function then is very, very huge, and we have, of course, neuro specialists. They are speech therapists who deal only with speech disturbances. speech. Then praxis, the ability to perform movements, and for example, how to ride the bike, how to like to drive the car, how to eat. We do it involuntary because of this praxis. Gnosis is ability to realize and analyze objects, to understand what it is, to has good orientation. And this gnosis also has different subtypes, and I will like give you like the subtypes. This is the ability to realize what it is. And of course, for gnosis, all sensory functions should be okay, not any other problems. Okay, then memory, speech. Patient who has problems with speech is aphasia, has aphasia, gnosis, praxis, executive functions. Executive functions like thinking, it's the highest level. Executive functions are provided by frontal lobe. And there it's our ability to analyze information, to like put the goal, find out which steps should we do to get it. If any problems, to switch from one step to another one to find out the better way. And then after gaining it, to go to the next level. And attention. Attention, one of the also important stuff, because without attention, we can't provide any other cognitive functions. It's impossible. That's why our level of attention is very important. For attention is a huge function. For this function, frontal lobe is responsible, and also reticular formation. If patient has problems with reticular formation, like patients with some neurodegenerative diseases like dementia with Lewy's bodies, it's Parkinsonism plus syndrome. These patients has atrophy there, and that's why the fluctuations of level of attention. That's why our attention level is absolutely important one. It's very, very important for us. And social intelligence. How we behave with other people in our like working and like learning surroundings. Can we understand emotions of other people? Our emotional intellect, how we can do it and analyze it. We all in real life, of course, these cognitive functions are assessed by specialist neuropsychologists or like neurologists who has specific dealing with these functions, because I do it in my real life like almost every day, and it usually takes me around 1 or 1.5 hours to analyze the patient. And of course in real, like in general practice, it's quite difficult because they have only around 20-30 minutes for one patient, sometimes even less. Okay, first of all, we analyze the consciousness of the patient. Is he in clear consciousness or decreased level of consciousness? Because if level of consciousness is decreased, then we can't perform all other tests, or we can do, but the result will be not real. That's why for examining all cognitive functions, patient should be in clear consciousness. He should not be sleepy. And only after it we ask him to perform our tests. We start, for example, if we talk about some scales that we use, if we talk about all patients, we have some scales like Edenbrook scale for cognitive functions. Also, one of the easiest one that can be performed by everywhere, it's mini mental state examination. Everybody, every neurologist should do this one. It's MMSE, mini mental state examination. This test is very sensitive for patients with Alzheimer's disease. Edenbrook scale is quite huge. It took around 1 hour to perform, but also very, very good. I'll write it to you. Edenbrook scale. And also MOCA test is the test for examining mild cognitive impairment. The patient is not demented but has problems with like difficult everyday skills like paying bills or learn new material of a huge amount, or some like PC operations takes more time and or have difficulties. Like this. And if we talk about attention, first of all, the patient of course should have normal level of attention, is very, very important for us. And also patients should like to work with you, because in real life many patients, they didn't like to work with the specialists, and they perform mistakes not because they can't do the tests properly, but because they didn't want, they don't want. And it's one of the most common stuff. It's when the patient has problems with emotions, patients in depression and anxiety, with apathy, they very often really dislike to answer you properly, even if we can. If we analyze attention, we have different types of attention. It's sustained attention, our ability to have the normal level of attention, to provide normal psychological activity. And decrease of concentration of attention we can see in everybody, everywhere, especially if we have lack of sleep, if patient has emotional problems, or if patient has overstudied. For example, before the exam, when you have a lot of material to revise and you don't have enough time for it. While you do this, your level of attention goes down. Then also we have selective attention. For example, we have different stimulus, and then in this case, the patient can figure out or analyze only one source of only one signal, and other signals he can stop and not analyzing it. And not to interfere with different interfering task or stimulus. Also very important for us to perform specific task, especially if it's very noisy outside. Divided attention, it's very important stuff for us in our life to perform different stuff at the same time. For example, if you drive the car, you can also talk to the person who sits next to you, or sometimes when we cook, we can also watch TV and perform all the stuff in quite good level. And divided attention help us to do it correctly. And processing speed, how quickly we can react to stimulus, to information that we get. And all these functions, all this stuff are very, very important. And how we examine our attention. These tests, of course, they have special time border. And one of the classical ones, how we do, find it, it is trial making test. I'll show you how it looks like. This is the stuff. Here is 25 numbers that are spread for the whole piece of paper. We ask the patient that he needs to draw it in the order, like in 1, 2, 3, 4, 5, 6, 7, up when he turns to 25. And when, of course, we measure the time. Normally, we do it at around, people of your age should do it at around 20 seconds, 20, 25 seconds, it will be okay. And for patients, of course, by the age of 60, it should be around no more than 1 minute. If more, then we try to find out what has happened. Another stuff is Schulte's probe, the same idea, 25 numbers in the screen or in picture, and patient should cross it in order, 1, 2, 3, 5, 4, 5, and etc. And again, we measure the time. It's very, very important for us. Test for divided attention, test for divided attention and sustained attention. For us, this is digit symbol test like this. You can see it. This is the code when each number has specific symbol on it. And then here is the training area. We ask the patient to put specific number step by step, not without any pauses, and ask the patient to put it below the symbol. Then here we turn on our time, we turn on and measure the time. Ask the patient to do it as quick as possible, and the patient has 90 seconds. And normally patient should put around 40-50 correct answers here. Now, of course, if you can do more without mistakes, it's great. This is easiest tests for attention. And of course, while talking to the patient, ask him about how old is he or she, date, name, profession also is important for us. We analyze the level of attention, because patients who have fluctuations, they will be with you, answer your questions, and then absolutely their attention goes down, and they even can't memorize your question because their level of attention decreases, and they even can't analyze what has happened. This is the classical stuff for patients with emotional disorders and patients with Parkinson disease and Parkinson plus syndromes, neurodegenerative diseases with Parkinsonism, especially Lewy bodies dementia. But we will discuss it next semester, the causes of cognitive decline. This is attention, or here in real life, for me, it's enough these two tests, because of course you don't have a lot of time to analyze all situations. Then after it, we examine executive functions. Executive functions, one of the most important stuff for us. Frontal lobes functions, analyzing all the stuff, how we do it. Here we can ask the patient to analyze, to give us the analyzing of picture, or also again, for example, I'll show you that, ask the patients how he can understand proverbs and sayings, because also it's ability to find out the difference and to analyze the stuff. Also, we can give the patient the picture, like here. So what you can see here in the picture, sorry, the quality maybe not very good, but what can you see? What has happened here?
A woman fell in a hole.
Yeah.
And some people are watching her.
Yeah.
And another man fell from the skis.
Mm-hmm.
And what else? There's a sign. And,
yes, sign means that this is attention, that here is ice, and yeah, you're absolutely correct. Yeah, one person put in the hole in the ice, this is river, and another one tried to help him, and other guys also. And here see some building outside.
Yes, a castle.
And yeah, normally your cognitive functions are okay. Normally the patients will tell us that here, this is winter, end of the winter, or it's of course about Russia. In other countries, they have very specific also other pictures for it. Person lies down in the hole, they were skating, and then goes down, other people try to help. Yeah, and this is enough. And patients with, for example, vascular disturbances because of strokes, because of this vascular anamnesis, arterial hypertension, all the stuff, they will tell you that, for example, in upper part we can see the building, looks like Kremlin. Here some person do somewhere. Other guys, and they will describe all the stuff. And they can't put these parts together to make analyzing the whole picture and to understand what has happened. And this is the special problem. This is problems with thinking that have patients with vascular disturbances. They can't analyze it quickly and correctly. For example, they understand some parts of it, but they can't put them in one correct idea how to tell. The same idea is to analyze proverbs and sayings. For them, it's also quite difficult how to analyze it. Also, we can ask the patient to has the ability, so I'll try to show you. Send 1 moment. When we ask the patient to give us to put 2 words into one category, to make categorization. For example, we ask the patient what's how you can name in 1 word apple, for example, and peach. What is it in 1 word? So how you can put it into one category, apple and peach.
Apple and peach.
Peach or lemon.
Fruit.
Fruits. Yeah, they are
Okay.
fruits. And for example, then we ask table and chair in 1 word.
Furniture.
Furniture.
Furniture. Yeah, then coat and jacket.
Clothes.
Fruits.
Animals.
Yeah, coat and jacket.
Clothes.
Clothes.
Clothes. Yeah. Then next step, it's like the easiest one. Then next one, it will be bicycle and train.
Transport.
Transport. And the difficult one is ruler and clock.
Ruler and clock.
Accessories.
Measurement, maybe.
Measurements, yeah, measurements. And patients with, again, vascular cognitive decline will tell you, for example, if we ask about table and chair, they will tell you that on table we can sit, and on chair we can sit. Or, for example, table we can eat, chair we can sit. They can't put it into one category to analyze it correctly. Apple and lemon, for example, one is sweet, another is sour. Or like another stuff about coat and jacket, that one is short, another one is long. It's impulsiveness symptom. Then patient first think, then do, or first do, then think, then can analyze it properly. It can't stop and can't analyze correctly what we ask the patient to do. And patients with vascular problems, they often have these big problems for it. And also examine the attention. Sometimes we can give special code to the patient. For example, we have a frontal assessment battery for frontal lobes functions. We can make the movement. For example, we touch 1 and ask the patient that he should give the sound twice. 1. I do 1, the patient do twice. I do twice, the patient 1. I give the command to the patient should remember the command, analyze it correctly, and then provide it at the same stuff as I've already told. The patients with frontal lobe problems, especially vascular problems, sometimes with tumors there, can't do it properly. They will have a lot of mistakes. And also we can see it in real life very, very often. This is what we talk about frontal lobes. Frontal lobes are very important for us. It's like SEO, or like it all our cognitive functions. And also our frontal lobes are responsible for our emotions and ability to do something, for our motivation. That's why it's the most difficult one for us to deal with this, especially vascular patients, patients with frontal temporal dementia, when they have apathy and lack of motivation, because they should, their relatives should behave like additional frontal lobes. They should do all the commands to the patient and then they will do it. But if no comment, they will sit or lie in the bed for the whole day without doing nothing. And it's a huge problem, especially for relatives. It's a big problem. And also emotional intelligence, how we can analyze emotions of our people, also is the highest one in our frontal lobes. It's important for all other stuff. Okay, just end one moment. So frontal assessment battery, yes, sometimes we do, but again, not really very often. Like attention, I already told you. As then thinking, it's all the stuff like here. And then thinking, like planning, decision making, feedback, analyzing, inhibition of non-correct movements. It's all about frontal lobes. Ability to this categorization, to analyzing, to synthesis, to comparing. It's all about frontal lobes. And for this, we have another test. This is trial making test part 2. First one will be to connect for this thinking ability. If I show you how it looks like. Here we have 13 numbers and 12 Russian letters. And we ask the patient to connect it like they are in our alphabet and with special rule. First we put, we have number and then the syllable or the letter that patient in Russian alphabet. One is A. One is A, then 1A, then from A we go to 2, 2 is B, then 3C, like 3C, and like this. Of course, in America and the USA, in England, they have like the same stuff, but with English alphabet. Idea is the same. The patient should analyze correctly the program. That first should be number, then letter, and do it without mistakes. If patients stopped or have problems to analyze the program, you can repeat it during the stuff, but only maximum twice, no more. And then you again fix the time, and normally the patient should do it no more than 1.5 minutes. Patients with executive dysfunction will do it longer, even more than 5 minutes, or for some, and even for some patients it's impossible to do it absolutely at all. It's quite difficult. This is trial making test part 2. Also, like, it's done everywhere in every country. It's quite easy one. And guys, 1 second, I'll show you another test that also can help us to analyze the thinking. Just 1 moment. Has a lot of stuff. Let me check if I have it here. Should. No. Okay, this is a Stroop test. The idea is in one you show, so I'll try to, guys, 1 second for me. Try to find the book where it is to show you. Yeah, it's like here it should be. Yeah, this is like Stroop tests. Can you see it? Not very good, but here, first part, dots with different colors. We ask the patient, of course, we fix the time, ask the patient to name the color of the dots from left to right. Patient do it, we fix the time. Second part, different words, like for example, flower, river, cut. Also, each word has different color, and we ask the patient to name only the color of the word, again from left to right, like step by step, fix the time. And then third one, the most difficult one, here name of colors, for example, yellow, green, red, and blue. Each color named is drawn is in different color. For example, it's written red, but it's the color of letter is red, difference. And the patient should also tell you only the name of the color of the words, only the color of letters. And here, if patient can't do this, means that he has problem with analyzing the program and inhibition, and he can't inhibit the incorrect program. This is again the test for frontal lobe. Quite difficult, but again, if you perform all this, you need around 1.5 hours to analyze all the stuff. And if patients has problems with frontal lobe and executive functions, how patient will behave? He will be spontaneous. The patient sits in front of you and absolutely no reaction to your questions. No, he will react, but like only like brief, short answers without any emotional control. And the patient will tell you, okay, for example, what is your name? Like, my name is Peter, and that's all, no other additional information. He will answer only to your questions with really like brief answers. If you ask about job, about family, we usually ask about wife, children, grandchildren to find out how patient remember it. They will only give you some short information and not like talk a lot about the stuff. And that's all. And while examining, he will look to the window or like absolutely indifference to what you would like to do. Another stuff, it's, so I'll tell you the name of the syndrome. One moment. Is also, we can see one moment. Okay, see it. When the patient has different stuff, like looks like philosophic, and the patient will tell you a lot of additional information about their family and can't fix the social distance. For example, this kind of patients can tell you about their sexual life, a lot of things. They try to hug you, to tell you like my doctor, like my brother, and even they can't understand the borders of another person. For them it's impossible, or sometimes they even come to the doctor and say hello doctor, and not you, like can name them even only by name, not surname, not full name, but only like by name. And sometimes they also can argue and say all these not very nice words that can be seen, that can be heard to them. And also sometimes they can answer you correctly, then switch to another topic, talk a lot about anything else, and then again come to the topic, then again, and give you a lot of short details that are absolutely not necessary to be known. And they even can't control it. Also, they can have perseverations. It's problem with also with thinking, when they can repeat the same movement or the same answer many times, and they can't inhibit the answer that they've already done it and repeat it many times. Or stereotypic think, the same idea, the patient can't do the stereotypic answer. You can ask him question, he answered it. You can give another question to the patient, absolutely indifferent case, and patient will tell you the same answer as before. Again, the patient can't stop and they can't inhibit the incorrect program and switch to another one. And when patient has severe problems with frontal lobes, the patient can have echopraxias and echolalias when patient repeats the same stuff after you. For example, you ask the patient, what is your name? And patient will also tell you, what is your name? You perform some movement like our probe, like is this probe for motor and for praxis, and the patient will repeat it after you many times, not other movements, but it's the sign of severe problems with frontal lobe. It's absolutely not very nice also for relatives. It's like this. Is it okay? Is it quite clear? I know that it's one of the most difficult topics, but is it more or less understandable?
Yes, but it's a lot of information.
I know. Yes, I know. I'm very sorry. Cognitive functions is the highest level here. That's why we can discuss it again on Friday. If you have questions, we can do it. I absolutely understand that the topic is very difficult, especially for you who like hear it for the first time. I understand. Then speech. Here you should know, because at the exam you will have only 2 tasks about cognitive function, 3. One person will be with frontal lobe disturbance and another patient will be with stroke with speech disturbance. If we talk, maybe you should know this, if we talk about right-handed people and also huge amount of left-handed people, where is the speech center, in which hemisphere, right or left? For predominantly huge amount of people. Who knows in which hemisphere we have our speech center? Left, of course, left hemisphere. That's why if patient has problems in left middle cerebral artery, especially strokes, these patients will have aphasia, problems with speech. And aphasia means that patient they knew how to talk correctly before, and after some problem, strokes, Alzheimer's disease, frontal temporal dementia, head trauma, the patient has problems with speech. Because if patient can't speak at the beginning of their life, it's absolutely different. And here you should know that our speech has 2, like here we have expressive speech and impressive speech. Expressive speech, it's our motor function, how we can produce words. And impressive, how we analyze and understanding of the speech. And here, for expression of the patient, expressive speech, we ask the patient to talk about himself, and in this case we analyze speech and also memory. We ask the patient about his name, his profession, date of birth, all his relatives, what he has done in the morning today, and all about and what has happened to him. After it, we also ask the patient to repeat some syllables and words after us and understand if they and analyze how he can do it correct or not correct. Because sometimes patients can mix words and mix syllables, mix letters in the words. Automatic speech, we can ask the patient to count 1, 2, 3, 4, 5, 6 up to 10, name the days of week. It's our automatic speech. Even with patients with huge severe aphasia, they still can do this. And also we ask the patient about the subjects, what it is. We analyze gnosis and expressive speech. Impressive speech, we give the patients commands, ask him, for example, to raise up his right arm, or to put his right arm to the left ear, or for example, in one of our tests, we have letter, close your eyes. The patient should read it and perform it without any hint. And by this, we understand if patient can understand what we say, what we tell him. And also in Russian, we have special words like daughter and dot. In Russia, these words changes in one letter. And we ask the patient, we show pictures, daughter and dot, and ask the patient, where is daughter, where is dot? And patients with sensory aphasia, with problems with analyzing, with understanding, they can't tell you correctly what it is. And of course, we cannot give the patient difficult constructions, like for example, we can tell you that ask the patient to draw the circle below the triangle, and for patient it will be quite difficult to do this. For aphasias, for you for exam, you should know motor aphasia and sensory aphasia, two big ones. And for motor aphasia, which part of brain is responsible, which lobe, and which specific zone of this lobe is responsible?
The frontal lobe.
Yeah, frontal lobe and Broca.
Precenter gyrus.
Yeah.
Precenter and
name of the zone. It has special name for it.
Broca.
Broca's, yeah, Broca's area. Yeah, this is for motor aphasia. Here, guys, no, I think, let me think, do you know this difference? Because in motor aphasia, we also have efferent and afferent, but I think it's too difficult for you because it's really for specialists who deal with speech specialists. But for exam, you will have a task about Broca's area disturbance. And the patient, this is efferent motor aphasia. Efferent motor aphasia. Patient can articulate normally, and he can't switch from one syllable, from one letter to another one. And in this case, how it looks like clinically, it will be pauses between words, between syllables. Sometimes patients can perseverate, name the same subject several times, and sometimes, or it will be a lot of the patient, the speech of patient will have lack of the lack of verbs, but will be a lot of nouns. A lot of nouns in the words, in the phrases, but and difficulties with nouns, difficulties with verbs, and big pauses between these syllables, between words. And but if you ask the patient to to sing, everything will be okay. You can also ask the patient to write the sentence, because writing is also speech, another function of this expressive speech. Usually these patients can read properly, no problem, they can understand perfectly, but for them will be difficult to write. They will have problems, they will have paraphasias, they will mix up letters and syllables in front of them. It will be quite difficult for them. Quite one of the most common types of aphasias in real life, we see them a lot. Another type of aphasia is dynamic motor aphasia. It's prefrontal areas. This is Broca's area, this is in front of it. The patient can repeat everything after the doctor without any problems. But here, this is lack of speech activity. The patient will not talk to you. He will only answer your questions, and that's all. Absolutely. No spontaneous speech, no or decreasing level of spontaneous speech. Repeating after you, absolutely, even big sentences without any problem. And then impressive speech, another task that you will have is sensory aphasia, problems with understanding. And problem in which frontal lobe, in which area for sensory aphasia that we really also see very often. So any ideas?
Wernicke's.
Wernicke's area, and Wernicke's area is temporal lobe. Temporal lobes, and these patients have problems with phonematic hearing. Phonematic hearing, it's like the part of language. It is like and putting phonemes together, we have word. Like some phonemes put together and we have a word, and for patient it's difficult to understand it. That's why the patient can't repeat after you syllables. For them it's impossible. And again, you ask the patient where is dot, where is dot, show the pictures, they can't understand the difference. They can't read because they can't understand what is written there, and can't write. For them it will be difficult. This patient can't understand the doctor and other people. That's why in this case they have like psychological reaction. They try to speak a lot of things, and absolutely without any sense, a lot of absolutely different words like this. And
Hello, hello, hello.
I think she had connection problem.
Safwan.
yeah, I'm very sorry. It's my internet. Looks like my internet connections died. No, it's here. Guys, are you still here? Are you still alive? Yeah, I'm very sorry. My
Yeah,
internet connection, my cognitive functions of my internet connection goes to dementia. Sorry, yeah, it can be. what it is. He can't explain it properly and can't show what to do with the stuff. Only can name some parts. This is like Boston naming test that we perform in all our patients. Okay, so one, what is it?
It's a bit.
Yeah, yeah,
Tree.
yeah.
Pen.
No,
No, pencil.
yeah.
House.
House,
Whistle.
whistle, yeah,
Scissor.
yeah,
Comb for hair.
yeah, yeah,
Flower.
yep.
What's his name? A saw for
Uh-huh.
cutting things. Toothbrush.
Yes,
Mushroom.
yes,
Hanger.
yes,
Camel.
yep.
Mask.
Mm-hmm,
Pretzel.
mm-hmm.
A chair. I like a chair.
No,
What's the name? I forgot his name, but in the
bench,
past.
bench.
Bench. Yes.
Yeah, see, my patients with, no, of course you don't have Alzheimer, but patients, again, they will tell you, okay, you will sit it on this in the park, but how to name, and then after it, we can give the hint to the patient. We ask the patient that this is, for example, first letter is B, then the syllable is B, and if patient has not severe defect, he can then remember the word. But if patient can't tell you what it is, you should tell him, for example, a hint that this is you can see in the park, or this you need to play tennis, like this. And this is
Tennis racket.
racket, yeah,
Snail.
yep.
Volcano.
Yeah, one of the favorite pictures of my Alzheimer patients, because it's a very difficult picture for them. Patients who has visual spatial agnosia and constructive apraxia, problem with visual spatial skills, they will tell you that it is skirt.
What?
Or skirt.
Skirt.
Yeah.
Okay, okay.
Yes. Or
Or
sometimes they will tell you that this is thunderstorm. Yeah, for them it's difficult to analyze it. This one.
Boat. Canoe.
Boat, yeah. This one.
Globe.
Globe, yep. This one.
Rhinoceros.
Yes.
Nut. Pine. I've got the name. Pine nut.
Yeah, I think you should. It's oak, but I'm not sure that you know what's this tree. It's our Russian one.
Okay.
Yeah. This one. This you
don't
should
know.
know.
It's two sticks when someone.
Yeah, where we can see it. Where this
in
person.
The circus.
Yes, yes, in the circus.
Dominoes.
Yeah, great. You know this.
Cactus.
Yep.
Escalator.
Yes.
What's the name? I forget his name.
Yeah, I know. I know that it's not
the
musical.
Instrument.
Yeah. Musical instruments. I will tell you the words. Of course, it's at the end words that we don't use every day. Of course.
Okay.
Harp.
Yes, harp.
Harp. Yeah.
It's called the hammock.
Hammock. Yep.
Hammock. Yes. Pyramid. Dog with a dog or the stuff.
Yes, the dog with what? It's another favorite pictures for my patients with Alzheimer. For them, it's the koshmar for them. What is there in his mouth?
I have no idea what the name is.
Muzzle.
Muzzle, okay.
Muzzle, yeah. And my patients with Alzheimer very often realize this picture is the pistol. Yeah,
okay.
Yeah, like they visualize it like this. Yeah.
This is a nozzle. where you put water on it to,
Yes,
and
I'll
also
check.
don't.
I'll check
Right.
the color. Who knows?
Maybe Ayman knows.
Flicker.
Funnel. Funnel.
Ayman, okay.
No,
Accordion.
yep. Yep.
I also don't know in English. Compass. Compass, I think.
Why do you need this one? Yeah, compasses. Yeah, compasses.
Yes.
Yeah, this one.
Painting brush and painting
Yeah.
board.
And this one, guys, nowadays, of course, we don't. Your generation will have difference between iPhone 6 from iPhone 7, from like Xiaomi, no, from other stuff. This is the very old stuff.
What's it called by Russian?
Счеты,
Счеты?
abacus.
Это понятно.
Yeah, abacus. And one of my patients, she is 16, told me that it is old calculator. No, like understanding. This is abacus or counting frame. You can, yeah. So Juan, your semantic speech is good. Absolutely, no
Thank you.
problem. No problem. Yeah.
Thank you.
You are absolutely perfect. Then, guys, another stuff. I know, yeah, you are. After it, you can drink a lot. I really like. It's very huge, difficult topic. Agraphia. Then patient can't. What? He can't write properly. But he has no paresis. His muscle strength is okay. This is again frontal lobe, like posterior parts of the frontal lobe. The patient, even in severe cases, the patient can't write absolutely, or sometimes he can change letters or can change words in sentence. For example, you can ask the patient to write down like, you have a huge black dog. The patient can write down absolutely different stuff. And here in this case, you can ask the patient to copy the sentence, to write it by hearing, or ask the patient again to write what he wants, spontaneous. But again, here the patient will have problems. And another stuff is alexia, when patient can't read because he can't understand, he can't analyze letters. That he looks to letter K, but he doesn't know that this letter is K, and can't put them together into one word. And these patients have problems in their posterior lobes. Very often we see them with patients with strokes in posterior cerebral artery. And of course, dominant hemisphere. Even in severe cases, the patient can't read at all, even louder, even like in any case. And if you can show letters to them, they can also analyze what letter is it. For them, it's quite difficult. In real life, we see a lot of patients with speech disturbances, a lot. It's a huge problem, and speech therapists really help us to do this. It's really good one. Then, guys, we can talk about gnosis. Gnosis is ability to analyze objects, subjects, and visual spatial skills. Also quite huge area of thinking, big problems that patient had them. I will give you brief stuff for it because, and again on Friday we can again discuss it if you have questions, absolutely without any problems. Guys, sometimes patients with gnosis disturbances will not tell you that, of course, I have problems with gnosis. They will tell you that they have problems with memory, that they can problems with memorizing and analyzing some root. Again, forget the name of subjects also. And not really, they will tell you that, okay, I have problems with gnosis is absolutely impossible. Here, what you need to know, again, left hemisphere and right hemisphere. One of the most common stuff is visual, one moment, the word like we examined here, this is visual spatial gnosis, not so special, visual subject. One moment. A visual subject gnosis, to understand that this subject is the same, is the real subject, that the pen is the pen, not other stuff. And how we show it already, so one perfectly show us no visual subject agnosia. Your gnosis is absolutely great. Or in classical mini-mental state examination, we show pen and show the watch to the patient and ask what it is. And here, usually this is posterior, temporal, or posterior and temporal, not temporal, sorry. This is, yeah, it's parietal lobe parts of left parietal lobe for the patient if he has problems with it. Also, patient has problems with here, like guys, temporal and parietal lobes left side, both ones. The patient also can have agnosia on colors. You can show the pictures of the same object, for example, triangle, or you can show like circles of different color and ask the patient what color it is. The patient can't do it. But if you can, and he even can't name it properly. But if you ask the patient what color is apple is, or what color lemon is, he will answer you absolutely correct that it's yellow without any problem. Problems with alexia, this is agnosia on letters. It's occipital, left occipital lobe. And simultaneous gnosis, another one, quite difficult one. It's analyzing the difference between two objects also. And also you need to understand that measure the distance between the objects. For them, it's quite, also for our patients, it's quite difficult. Guys, for visual subject objects, for visual subject gnosis, we also can give the patient special pictures and ask the patient what he can see there. It's if the damage is not very big. And Safwan, again, you will be the rabbit today. I'll show you the picture. See that these objects, they put together and one by one. Can you please tell us what you can see in this one?
Okay, in that one, I see a bucket, scissors,
yeah,
an axe.
Yeah.
The thing they grab leaves with.
Yes, yes. Perfect, perfect. And this one?
This one, a lamp, a key.
Yeah.
And I think that's it. What's that?
You can tell me what to do with this subject.
I can't see it actually. I don't. A lamp, a key, and.
Yeah, this is the stuff that you hang it. You put water inside it.
Yes, it's the big cup.
Oh yeah, well, like, okay, big cup is okay. And the most difficult one for the patient, we show this picture. See here, half of the objects.
I need to. I need to recognize what it is.
Yeah, you need to recognize what it is. Like
So
this one.
it's, I actually can see very well. It's
Yeah.
maybe light bulb.
Yeah,
Light bulb.
this one.
And that one, it's letter J in Russian. I don't know.
No, ведро, bucket.
Okay, the thing.
Yeah, this one you should know.
That one, it's a cat. I don't know.
What you can do with the stuff.
I
Guys,
have no idea what it is.
Guys, any ideas what it is?
Middle one is it bubble?
What you will do with it?
Boil some water. I mean middle one.
Yeah, yeah,
Yes,
but this
yes.
one, it's teapot. Yeah, and this one,
Is it a knife?
it's a knife. Yeah, and this
Okay.
one.
It's like the
Using that.
balancing. Wait.
Yes.
This one.
Spoon.
No.
Scissors.
Scissors. This
Scissors.
one. Yeah, this one.
Glasses.
Yeah, glasses. This one.
Key.
Okay, perfect. Yeah, and it's one of the most difficult stuff for the patients to analyze, and it's like for short problems. For visual spatial skills, this is very huge connection with constructive praxis, visual spatial analyzing, ability to understand where is right, where is left, ability to measure the distance between the objects, ability to dress, because it's also important, where is right, where is left part, read the map, follow the navigator, orientation in time and space. It's very huge one, and this is left temporal and parietal lobes. In this case, the easiest one, we ask the patient from mini mental state examination, we ask the patient to copy triangles. I will show it to you. We ask the patient to copy pentagons, and ask the patient to draw the cube, and also ask the patient to draw the clock drawing test. Okay, Safwan, can you please take the piece of paper?
Yes.
Yes, I know. Good.
Okay, I have piece of
Okay,
paper.
we ask the patient to draw the circle and put all the numbers inside the circle, how they are on clock.
Okay. So wait, I need another paper.
And please show us.
Okay. Just a moment.
Yeah, no problem. I hope there is no hints. There are no hints in front of you.
Yeah.
This is very good test for frontal lobe functions and also for visual spatial connection for temporal and parietal lobe, left one. Are you ready?
Yeah.
Can you please show us your clock?
Yeah, I think
Perfect. Yeah, perfect. And then we ask the patient to put the arrows that they should show the time quarter past, quarter past 1.
1:15.
Yeah,
So it means
essentially past or before. 1 hour 45 minutes.
okay.
Yeah, looks like past. And let's show you the stuff of my patients.
I think,
Perfect. See here, 10 points from 10. All numbers are at the same line. 12 is opposite to 6. 3 is opposite to 9. And arrows, we see difference between clock and minute area. And then here is the very good test for us, because if patient has problems with putting the arrows and with the correct time, we, for example, give the patient real watch and ask the patient what time is it now. Patients with visual spatial agnosia or dysgnosia and constructive dyspraxia will have difficulties to analyze the time. And short defect, like small defect, they will have difficulties in putting arrows correctly, but they can still analyze the time on watch. Huge defect, they can't absolutely do both stuff. It's impossible for them. And also, if it's they can have problems, we can give them like special tests. We can give them these clocks and ask the patient what time is it now also. And here, for example, if patient can draw the clock with problems, we can draw the correct clocks to the patient and ask the patient to copy. If the patient can't copy it normally, means that patient has problems with frontal lobe. But if patient even can't copy, means that patient has temporal parietal lobe problems. And now I'll show you my Alzheimer patient. She's 64-year-old. This how she draw. Here, this is her pentagons. How she do it. This her cube. See, this is my cube. She can't do it herself. Then I draw the cube and ask her to copy. If patient can copy normally, means that he has problems in frontal lobe with analyzing and programming. If patient still can't do it even with the hint, means that the problem is in temporal parietal lobe, is his visual spatial problems. And her clock, see, she even can't put the correct arrows, is not correct, and she even can't put all numbers here. It was difficult for her to do it. Yes, and another stuff with the clock. And here the clocks, patient has both dysfunction frontal lobe and temporal parietal. See the patient put numbers not inside but outside the circle. And also here she starts she put it 12, 13, 15, 14. This is frontal lobe impulsiveness, then patient can't stop and can't have the correct figure and do it not correctly. And very often they will write it down to 24, 23, 25, and even can't stop. It's frontal lobe dysfunction. But guys, in real life, patient can have dysfunctions of both frontal lobe plus temporal, occipital and temporal lobes. Just I will try to show you another great one. It's the real patients. Yeah, this is classical patient with Alzheimer disease. Have a look how she draw pentagons. See, this is my pentagons. This is how she draw it. See that she absolutely can't copy it. This is mine, this is her. This is visual spatial, well, this is constructive dyspraxia. And also cube. See, this is her cube. How she can do it. Patient with Alzheimer. It's difficult. No clock, absolutely, like numbers, but she still can't copy it. And when I show her normal watch, she also can't analyze where the stuff is. Okay, guys, I know that you are very tired. If you want, we can discuss memory, and on Friday we can continue with praxis stuff, and also Safwan, we will measure all your other cognitive functions, how it will be. Because I really understand the topic is difficult and you are quite tired.
Okay, I think it's better.
Yeah, guys,
I'm
another
a little
one,
bit
others, guys, I also would like to hear anyone else except Safwan. Guys, everybody is dead.
Yes, we are here, but okay, like we can complete in Friday.
Are you still alive or absolutely
No.
Not alive?
No, kind of.
Kind of, yeah, got it.
Yeah,
Okay,
me too.
guys, then the last two key points that you need to know, the last important stuff, and that's all. I understand. Yeah, topic is absolutely big and usually it takes around like 2-3 classes. For gnosis, if we talk about right hemisphere, right parietal lobe, the patient has very important syndrome for us. The patient has anosognosia. The huge problem in our rehabilitation of patients after stroke, because if patient has this defect, he can't realize that he has a disease. One of our patients with right parietal stroke in this area with severe left side hemiparesis every day asked us to go home and told us that she can absolutely do everything by herself, but she can't because she was supine patient with even plegia in her left extremities, and you even can't tell her that she has this problem because she can't analyze it. It's a big problem for us to deal with this kind of patients, because in process of rehabilitation they will not do all this necessary stuff because they can't realize that it's really necessary for them. Huge problem. Absolutely. And another one is neglect syndrome that all of you maybe hear, when patient can't realize the half of the space. It's more about attention now, but also it's one of the like subtype of agnostic parts. For example, you ask the patient to copy cube, like triangle or something like this. In this test, we ask the patient to copy the house. See, the patient can copy only one half, and he can't analyze that there is another half of the object. The same idea, if these patients eat, they eat only from one half of the plate. They can't do it from another one because they can't analyze that this another part is real, like this. Okay, and the last key point, that if patient or your relative or someone tell you that they have memory problems with remembering, recalling, and storage information, it's always a symptom of something. If we talk about young patients, it's very often thyroid gland problems or depression, anxiety. And if we talk about old patients, it's one of the key points of Alzheimer's syndrome. That's why normally, like here, it's a huge problem in Russia that many people think that if patient has memory problems, memory loss, it's normal for aging. In normal aging, patients never have memory problems. Only, it's always a symptom of the disease. Got it?
Yes.
Yes.
Yes, I understand. Okay, guys, then on Tuesday, you will discuss sensation, sensory pathways. Mahmoud, if I'm not mistaken, I'll send you
Yes.
the Mayo Clinic book.
You have sent it to me like with some silly picture. You sent it to me like
Yes,
not
and
clinical.
also link for my Google Disk with Mayo Clinic Medical Neurosciences. Can you see it?
Yeah, I saw it, but I didn't download it. I will download it and share it with my friends.
Please, download it and share with others because there are
Sure.
absolutely brilliant pictures for sensory disturbance. And this book
Right.
is quite difficult, but pictures absolutely fantastic there. And on Friday, we will discuss 3, 4, 6, and 1 and 2 cranial nerves, not very difficult. And we will discuss praxis and memory. I will show you how to examine memory and what's the difference between hippocampal memory loss with other subtype, how to differentiate Alzheimer's disease clinically. Okay? Safwan, and I really would like you to be on Friday because you will be the rabbit.
Yes, sure.
We will examine your memory.
I hope it will be good.
Okay, then we have like another rabbit if Safwan will disappear for Friday.
Professor, Friday, which is tomorrow, right?
No. Friday is 1st of October.
All right.
Yeah, I guess. Tomorrow you should have something else.
Yeah.
Yeah, I know the topic is, and please read again this topic. We will discuss if you have any questions. Not a problem, because on next Friday I will have no limit. I will have no limits, no time limit. That's why, like, every questions that you would like to discuss, you're welcome if you have them.
Professor, I have a question. Like, what is the date of our exam?
At the exam, you will have the task about motor aphasia, the patient with stroke in middle cerebral artery. So motor aphasia, you need to differentiate it and find out. And another task will be about frontal temporal dementia, behavior changes.
Yeah, I mean, it will be as a shoot and then exam, or
No, at the exam, it's the task about exam.
and the exam it is in October, or
No, exam will be next semester.
the next semester. I thought like we will have the shoot and then exam or something.
No, exam will be only next semester. This, guys, according to new rules of our university, you even can't go to classes. You don't need to have zachot for going to exam. But I think Luis Talgatna will ask you some questions.
We didn't get it, Professor.
Yeah?
We don't know. We didn't get. We shouldn't attend the classes which includes the shoot.
Yeah, I think yes. I'm not sure that maybe Luisa Talgatna will give you some special questions, but I'm not sure.
And if we like offline student who is in offline now, like they attend in, they see patients or in neurology, I mean.
Guys, sometimes yes, but I'm not sure really that they do it. Because of this, again, coronavirus problems. I think they can see. Luis Talgatna next time should show you some videos of peripheral paresis. Ask her, because on our first class, Safwan, yeah, remember I should show you the picture with spinal cerebral ataxia video with Parkinson disease.
Yes, you showed us.
Yeah, that's why here Guys, with cognitive functions, I can show you only the pictures of my patient. For this specific topic. But for sensory disturbances, I think Louise Talgatna should show you some videos of her patients.
Yes, she sent it to us.
I think it's like this. Okay, then on Tuesday, Louisa Talgatovna and sensory disturbances. Do you have class on Thursday also or not? Next Thursday, I mean.
We
Yes, I
maybe
think
have.
Genetics.
You have, yeah?
Yeah, it's usually
okay.
on Monday, Thursday,
Okay.
from 9 until 12.
Okay, and then Friday. Guys, at Friday, next Friday, which time should we start? At 1 or earlier?
Earlier, please.
Yeah, I can because here, did you have genetics here in the morning?
1 minute, Professor. Like, I will check the timetable to have some.
Yeah, please, please, because on Tuesday we have problems with schedule.
On Friday, we have internal medicine in the morning. So I think at 1.
At 1 again. Internal medicine on 1st of October, yeah?
Yes.
Okay, then please let on
I think at 1 or after 11, because I don't know when we'll finish.
Yeah, it is finished 11:30, so
yeah, guys, but you need 30 minutes to refresh your brain because you die here. I don't want you.
It's finished in 11:30, so we'll have 1.5 hours.
At 1, yeah?
Yeah.
Okay, then on 1st of October.
If it's possible for my friends, like I'm talking about myself.
Then please let's discuss it like among you. Again?
Maybe 1:30.
1:30, okay. Guys, for everybody is okay, 1:30.
Yeah,
okay, then 1:30, 1st of October, we will discuss Finnish memory and praxis. And then we will discuss 1, 2, and 3, 4, 6 cranial nerves.
Okay, Professor.
Okay, see you. Thank you very much. And I hope that you still tired, but not up to 0.
Yes, I'm going to eat now.
Yeah. Bon appetit to everybody who would like to eat. Who would like to sleep, have a good sleep.
Thank you.
Okay, see you. Bye-bye.
Bye.
Bye.
Bye-bye, Professor.
Thank you, Professor.